You're listening to the Better Women series of Matters of Engagement. We're a podcast examining issues at the intersection of health, healthcare, and society. I'm Jennifer Johannesson.
And I'm Emily Nicholas Angle.
We're excited to bring you this special 5-part series in collaboration with the Canadian Cancer Society and Women's College Hospital. As you'll soon learn, they joined forces to address one of the pressing issues facing both public health and primary care medicine, and that is how to support people in preventing chronic disease through lifestyle behavior change.
Stay with us for a journey through the Better Women Research Project, and we'll learn together about its potential for positive impact on the health of Canadians everywhere.
Welcome back. This is episode 2 of 5 of the Better Women series, where we get into the nuts and bolts of the research project itself.
Yeah, as much as we're in and around healthcare research projects all the time, we don't really get to talk much about the finer details of research protocols, especially in an implementation project like this.
There's a lot of moving parts. I'm excited to get into it.
In the last episode, we talked about how our healthcare system is, well, completely overwhelmed everywhere, and especially in primary care and family medicine. Family physicians have a hard enough time keeping up with acute issues and aren't really able to give enough time and attention to prevention, which is helping people change their lifestyle behaviors and keep up with screening in order to either catch issues early or prevent health problems from developing altogether.
Yeah, and we talked about moving investment upstream, where people are supported in prevention measures and encouraged to live healthier lives. And this can't really be done reasonably under current conditions.
So, we talked about ways to bolster existing primary care practice throughout the province. The Canadian Cancer Society and Women's College Hospital have teamed up to explore exactly that through the Better Women Research Project. Better Women evaluates the use of prevention practitioners and peer health coaches in facilitating people's desired behavior change.
And it's not just related to cancers. So many chronic diseases and conditions have similar origins. We could try to tackle each individual one at a time, but the further upstream we go, the more likely we are to cast a wider net and improve the health of more people. Okay, so who's starting us off?
We've got Dr. Eva Grunfeld again. She's a consultant on Better Women and was the co-founder of the Better program and led the original study.
Rarely do we, as the public or patients, hear about the interconnectedness of prevention and screening for all of those conditions, and more broadly than just cancer, all the chronic conditions as well. Most people don't realize that if you think about the factors that can lead to prevention of diabetes, well, those are exactly the same factors that will lead to prevention of heart disease, of many of the cancers, of prevention of arthritis. Those, what we call upstream factors that are amenable to prevention, actually have a much more profound effect than we usually realize because we're talking about them in a very fragmented way.
Dr. Grunfeld is just one of many people we're talking to as part of this project.
Yep, so we're chatting with scientists, researchers, physicians, evaluators, and more, who have all been part of Better Women and its predecessor projects, to get a sense of not only the research at hand, but the possibilities for the future. You'll maybe recall the original Better project showed that the addition of a prevention practitioner to a family medicine practice allowed the practice to support more patients with screening and prevention. Then why Better Women?
We started to ask the question, what happens 6 or 12 months later?
That's Dr. Noah Ivers again. We heard him last episode. He's the evaluation lead and co-principal investigator of Better Women. We asked him why he thought this extension project to Better was needed.
Do those changes that happen for the patient get sustained? What would it look like to try to keep supporting patients over time? And so we started bandying about this idea of community health workers or peer health coaches to play that role, and what it would take to train a cohort of such people, and what it would take to evaluate whether that made a difference, and what partners we would need to explore that. And so as we started brainstorming this idea that everybody started to get kind of excited.
And here's Dr. Grunfeld again.
The key thing about Better Women, which makes it unique, is that the original Better was designed to be practical, doable in a primary care practice, which means that, it's always, there's limited amount of time and there's a limited amount of, availability of human resources. So the Better Women takes the kernel of Better and augments it, makes it, hopefully, that's what we're testing, makes it more profound, more potent by linking the patient after the prevention visit with a peer health coach.
Okay, so let's talk about the project itself. Better Women is a collaboration between Women's College Hospital in Toronto and the Canadian Cancer Society, and together they received additional funding from the Public Health Agency of Canada.
As a research organization, Women's College Hospital not only tackled the evaluation piece, but was also instrumental in putting together the research team and protocols. The Canadian Cancer Society has vast experience in managing and training volunteer health coaches, and has access to a wide pool of participants and volunteers. So it's kind of a perfect pairing.
Yep, and they work seamlessly together as a project team. Moving ahead through this podcast series, we'll really only mention each institution as needed. Together, they're the Better Women project team.
Okay, so we're going to put a bunch of reference material in the show notes. If you want to do a really deep dive into this project, head on over to our website.
Okay, so let's summarize the Better Women Research Project. Do you want to give it a shot?
Yeah, so I've been thinking about how best to do this. Okay, let's break it down into 3 things. There's the premise, like, why do we want to do this research? What don't we know? Then there's the intervention, or the tool that we're going to test out. And then there are the research goals. Okay, so to start with, the premise is that the healthcare system is overburdened, with primary care feeling particularly stretched these days. Good results are seen by using prevention practitioners. But, as Dr. Ivers said in the last episode, what happens months or years later?
Right, so do people stick with their changes?
Yeah, so the idea for an intervention to address all this, well, what happens if we train volunteers? Just regular people like you and me, to support patients in helping them change behaviors to accomplish health goals.
In the Better Women Project, these volunteers are called peer health coaches. They work in conjunction with prevention practitioners. You might recall we described them in the last episode. They're the designated person in the primary care practice who is specially trained to follow up with patients about setting health-related goals to aid in prevention of chronic disease. The peer health coaches then carry on the work of supporting the patient to make lifestyle changes to potentially accomplish those goals.
Exactly. You can read all the details of the protocol in the paper that we link to in the show notes, but just to get a bit more in the weeds here, let's go over the 3 questions the team formulated to track and report on. Okay, so let's see. Okay, number 1 was that they were going to see whether participants stuck with their health-related screening and lifestyle goals after 6 months.
And number 2 is they're looking at what are known as process measures. So this is more about the delivery of the program and how it's implemented and whether it went as planned, as opposed to the outcome of the program.
Okay, so number 3 here is, did participating in the program have an impact on long-term health for those who completed it? So, did it have an impact on things like cardiovascular risk, or did it reduce encounters with the health system? Did their health status improve?
Yeah, brilliant. Okay, so we've got the basics down. In order to run the study, they had to recruit participants who were the patients that needed support, and also recruit a bunch of people to become peer health coaches. And then they needed to develop training for those coaches and match the patients with the coaches.
Yeah, I think people don't often realize how many moving pieces are involved in research. Remember, the study was also divided into 3 cohorts. There was the Women's College site, which mostly served urbanites, or people who live in the city of Toronto. And then there was the Barrie site, which is just a little bit north of Toronto, and it had a partially rural population involved in the study. And then there was the Somerville site, which had primarily women of South Asian descent. They did this to see whether demographics make a difference, to study outcomes, and also to model out how to implement peer health coaching in underserved communities. Better Women is a randomized control trial. So that means patients enrolled in the study were randomly divided into those who would receive coaching right away for 6 months. That's called the intervention group. And those who would receive coaching later, starting after 6 months. That was the control group. Now, both groups were tracked over those first 6 months. This way, they could compare outcomes for those who received coaching and those who didn't.
So, the control group who didn't get coaching at first did get it later.
You've got it. So, they wanted to provide coaching to everyone eventually, regardless of which cohort they were in. And, this is really important for fairness and from an ethical perspective. Okay, so all participants were surveyed and had their health markers tested at the very beginning, at 3 months, at 6 months, and at 12 months. Now, the coaching itself lasted 6 months. So this way they were able to track if participants stuck with their changes several months after the coaching had been finished.
Most research projects I've encountered often run into challenges with recruitment. It can be really hard to get the word out to the people you're seeking, even in the best of circumstances. But it can be especially hard when there are language and cultural considerations, and if the research team itself isn't already embedded or connected to the community.
Actually, they thought of that. The Canadian Cancer Society has lots of experience, and they help to recruit participants by engaging specialists who could support community involvement right from the beginning. Shabina Amlani was one of those specialists who helped to bridge communications.
Because this is a research project, we wanted to compare these 3 different sites and what is the best way we could connect participants to their peer health coaches. Because the Somerville site was targeting the South Asian community, we needed to recruit South Asian peer health coaches that spoke South Asian languages so that they could support the South Asian participants or patients of Somerville Family Health Team. So that guidance and how do we recruit these peer health coaches? How do we recruit the participants? What does the communications, posters, translations, what does that look like? All of that support came from the Community Advisory Committee. We were also on a lot of South Asian media channels like Omni TV. We were in Desi News, which is a publication that's online and printed for the last 30 years that reaches out to the South Asian community. So we used many models of communication to talk about the program and to engage with the South Asian community.
Yeah, this is exactly right. It's definitely not enough to just say, "Oh, we speak your language." You do actually have to go out and engage with the community in their language, obviously, but also in the spaces where they receive and trust information already. Okay, so now that the research questions are sorted, the participants are recruited, and the matching has happened, the actual program is underway.
Enter the peer health coaches. Like we've said before, they're the heart and soul of the program, and we've devoted a whole episode to their experiences and insights.
Yep, that one's coming up next. But for now, why don't we include some of that conversation we had with Nalini Sharma?
Oh, for sure. She would be great. She was a peer health coach trained within the pilot. Like most of her colleagues, she was really taken with the motivational interviewing. Let's share a part of our conversation with her. It really gives a sense of what some of these coaching discussions were like.
Okay, the motivational interviewing, the woman that I'm saying, she was really, really, really good.
Nalini's referring to Dr. Maya Badia, who trained the peer health coaches on motivational interviewing.
Role playing, sometimes we'd be in breakout rooms, and then she would jump in and be acting as the peer health coach. But she would really show us how to keep asking the questions instead of saying, "So, how are you?" "Fine." "How was your week?" "Good." Those are not the types of questions you should ask. You have to frame it in a way that that person wants to tell their story of what happened. in the week. So you have to set parameters. What were you most proud of this week? Is maybe something that I would ask my participant. What made you happy this week? And then they'd be like, oh, well, you know what? I actually took a walk on my lunch break and I felt really good about that. Oh, really? Is there a way you think you can build on that going forward next week? If you did one walk this week, do you think there is a way you can build on that? And if so, what would you do? Oh, okay. Well, I'll write it in my agenda, or I'll take my shoes, my running shoes to work with me. It's just about you keep asking. Like, I would never tell them, you should go for a walk, or, you shouldn't eat that. I never, ever, ever said that to them. I just tried to frame it so that they would have to ask themselves the question and come up with the answer. That's really what a peer health coach is, at least in the training that I received.
When I first heard about peer health coaching, I did kind of wonder, like, how is this different than just talking to a good friend? Isn't that kind of what friends do? Just listen and encourage?
Yeah, but it's actually completely different. We asked Nalini if she thinks that she could have jumped right in without any training.
Yeah, there's no way, because then I probably would say something like, why don't you just go for a walk? Which is not what you're supposed to say as a peer health coach. But, 'cause that would be as if I'm talking to a friend or a colleague, or, they're complaining about this, like, I would say, just walk, like, go outside, go for a 10-minute walk, clear your head. And, and that is, that's pushed to the side, and you are really there to help them motivate themselves, because change only comes when you want to do it on your own.
Definitely more to come from the peer health coaches in a different episode. For now, we're going to fast forward to the part where the pilot program is actually finished and all the data is gathered. And that's actually where we are in time right now as we record this, in the evaluation phase. So, we're going to meet some of the evaluation team. And first up is Natasha Kithalagoda. She's the manager of the Office of Spread and Scale at Women's College Hospital.
Our role as Women's College Hospital was to evaluate the program and see if it was successful in improving healthy behaviors of participants. We're trying to learn from this data to inform future iterations of this program or other chronic disease prevention and screening programs in primary care.
So then, looking at the broader evaluation team, we've got Anjana Rao, who performed both qualitative and quantitative analysis, and Rochelle Simmons, a research assistant who primarily supported the quantitative work.
To make sure we're all on the same page, what's the difference?
Well, quantitative is all about things you can measure or observe. It's gathering data and crunching numbers. Qualitative is more about evaluating someone's experience or their impression, or maybe it's about the process. Often qualitative data is gathered through more open-ended kinds of discussions or surveys. Questions might start off with something like, tell me about, or what do you think of? Okay, so let's get back to Rochelle. She starts off with data abstraction, the phase that they're in now. You'll notice she mentions EMRs, which are electronic medical records.
So data abstraction is a quantitative task. So that's basically where we're going through participants. We're going through the EMRs, there we go, of the different sites and pulling their information. So when did they complete their cancer screening? So that's colonoscopy, mammogram, PAPS. We're getting their blood work, whatever we're looking for. So usually that is glucose, so like diabetes screening, we're looking for blood pressure, BMI, those sorts of things. So actually pulling the data that has been tested in some sort of way, formally tested.
So that was Rochelle. Here's Anjana.
So I take care of the data aspects, the quant and the qual, but most of my work is revolving around the qualitative aspects. So this includes conducting interviews, doing revision of the interview guides, if needed, or whenever needed, collecting data from patients who participated in this trial, but also the peer health coaches who were trained, as well as the prevention practitioners.
We asked Anjana if there were any early impressions of what she was seeing, or anything that kind of stood out. And we promised not to hold her to it.
I say this anecdotally because this is what the peer health coaches had presented to me. The difficulties that patients had was taking care of their families. They not only just cook for themselves, they cook for the whole family. And a lot of these families not only just have their husband and kids, but also have their in-laws or their parents. Some of these families are quite communal. There's just not enough time to take care of themselves. And their health is put back behind. All these other responsibilities come first.
It's an interesting point Anjana raises about families being quite communal. While that's true, that doesn't mean people are talking to each other about health goals or health issues. In the last episode, we heard from Christine Brooke-O'Leary speaking about loneliness and about the benefits of having a cheerleader and having someone in your corner. Dr. Grunfeld reinforces this idea, recognizing that it's not just the health impacts that are meaningful, but also that sense of support.
I would say the overarching theme was a real gratefulness to have a dedicated amount of time specifically focused on this topic, which doesn't typically happen. So I think that would be, the overarching way I could describe the feedback that we got from patients. It was that this was a unique and really welcome opportunity to have a one-on-one intense conversation with a health practitioner, which is focused specifically on prevention.
Yep, the prevention practitioner. Their role in this is so important. They're a key link in the chain of support. It must be so gratifying to work with patients on developing their health goals and then handing them over to a trusted and trained peer health coach who you know can offer meaningful support.
Yep, absolutely. We spoke to Nicole Thomas. She's a nurse in Barrie working with Dr. Arava. We heard from him in the first episode. So she was trained as a prevention practitioner for this pilot project, and she really sees the value of peer health coaching for her patients.
I think sometimes as healthcare providers or working in healthcare, that we sometimes can gloss over and forget that even though we work to build a therapeutic and comfortable relationship with patients where we want them to be able to feel like they can be open and express any concerns or, tell us about their goals and if they're meeting their goals, that it's still not the same as if they were speaking to somebody, like you mentioned, who may have had similar lived experiences, maybe even, just similar demographics at home or that sort of thing. So I think it can really help people open up. I think somebody that's maybe a bit more neutral and you're going into that conversation with the intention of talking about goals and goal setting and meeting those goals. And if they can reflect back on lived experiences that they've had, I think that can be really helpful. I wish everybody could have somebody like that. That's what you hope for. And I know many people that we see in a day don't.
It's one of the tough parts, I think, of being part of a pilot or trial, knowing that not everyone is going to get to benefit, at least not yet. Anyway, it is still yet to be seen whether the addition of peer health coaches is going to have longer-term positive effects and whether the additional coaching is actually going to help patients stick with their behavior change on their own. And that's really what this study is all about.
I think our evaluation needs to determine whether we did a good job with that. One of the ways we want to explore that is we built in quantitative evaluation of about 6 months after the coaching ended. Were people still doing the things that were in their plan? Were they still exercising? Were they still up to date for their recommended blood tests or their cancer screening or what have you? Did it sustain? We'll let you know when the results are out. I hope we did.
By the time the series wraps up, we'll have been able to circle back with some of the team, including Dr. Ivers, to find out whether their hopes for the project were realized. It's a lofty goal, to shift the paradigm of healthcare, or more specifically primary care, to one that focuses upstream, to potentially reduce the immense burdens that chronic disease and cancer place on affected individuals, as well as the system itself. However challenging it may be, it's a path worth pursuing. And the inclusion of peer health coaches hopefully represents an innovative step in the right direction.
If it means that more Canadians are going to stay on top of their testing, and that means we can find things quicker, prevent things more effectively, then that's what's most important.
Well said, Rochelle. There's a lot of hope that there may be a ripple effect here in terms of patient outcomes and also for volunteering and future peer health coaching projects. Here's Karen Kuzmich. She managed the project for the Canadian Cancer Society.
You know, the ripple effect of this kind of program is interesting because those that have heard about it, we're hearing that, oh, well, my mother would love to be a volunteer as well. Or could my sister or mother who lives in that particular community, could she get matched with a volunteer peer health coach? I really hope and I look forward to the next phase of this project when we get to disseminate further the results and the outcomes, where we start spreading the news and then really hoping to spark other light bulbs to go off and say, well, what is the potential now?
Okay, that's a wrap for now. In the next episode, finally, we're going to profile the peer health coaches. Thank you so much for tuning in. Bye for now.
See you next time.
This series on the Better Women Project was brought to you by Matters of Engagement in collaboration with the Canadian Cancer Society and the Better Women research team at Women's College Hospital.
Special thanks for editorial and administrative support provided by Karen Kuzmich, Christina Macri, and Shabina Amlani at the Canadian Cancer Society, and to Natasha Kathulagoda at Women's College.
And a big thank you to all of our guests on this episode. Dr. Eva Grunfeld, Officer of the Order of Canada, Physician Scientist, and Professor Emeritus at the University of Toronto. Dr. Noah Ivers, Scientist and Family Physician at Women's College Hospital and Canada Research Chair, Tier 2, in Implementation of Evidence-Based Practice. Shabina Amlani, Senior Specialist, Better Women, Canadian Cancer Society. Nalini Sharma, Peer Health Coach with the Better Women Project. Natasha Kithalagoda, Manager of Implementation Science at Women's College Hospital. Rochelle Simmons, Research Assistant, Better Women, Women's College Hospital. Anjana Rao, Evaluation Specialist, Better Women, Women's College Hospital. Nicole Thomas, Registered Nurse and Prevention Practitioner. Karen Kuzmich, Manager of Cancer Prevention, Canadian Cancer Society. This episode was written and produced by Jennifer Johannesson and Emily Nicholas Engel. For a transcript of this episode and for more information, please visit mattersofengagement.com.
The end of the Canadian Cancer Society's CIBC Run for the Cure is just the beginning, because the funds raised through the run continue to fuel life-saving breast cancer research, enable clinical trials that improve outcomes and bring you hope, and help patients every step of the way with vital support services. Join us October 5th and make an impact that lasts far beyond. Sign up at cibcrunforthecure.com.